hypothyroidism, the metabolism is very slow. You have a list of physical characteristics that occur with hypothyroidism. However, one trait that needs more explaining is the myxedema that you see here with this gentleman. This occurs when there is an altered composition of the dermis and the underlying tissue. The connective tissue becomes loose as proteins and mucopolysaccharides accumulate there, and then those bind to water and just hold the water there, and so you have the edema. It is most often seen in the face and usually under the eyes. Here on the right, you have an example of creatinism. This is the result of untreated congenital hypothyroidism. The cause for this is mostly iodine deficiency worldwide. While congenital hypothyroidism can be corrected if treated early after birth, if it is left untreated, severe blocks in physical and neurological growth development can occur. The picture on the right is a picture of a 30 to 40-year-old female. Besides the small amount of breast development, the person is probably similar in size to a 4 to 6-year-old and might have the mental status of a 4 to 10-year-old. This is an example of neonatal hypothyroidism, if occurring in utero, such as the mom has untreated hypothyroidism, or there is a lack of development of the infant's thyroid, and the signs and symptoms can be obvious at birth. Generally, the birth weight is quite high, so just in an adult who has hypothyroidism and can gain weight very easily, the infant gains weight in utero unnaturally. The tongue can be quite large as well due to edema. Right? And this, even though the face here is very puffy and, fat, overweight, the tongue is obviously quite large as well. We're talking about a newborn, an infant just arriving into this world. So it is important for quick treatment of this infant and close monitoring of the different thyroid levels. Feeding can also be difficult at this point because of the very large tongue. Excuse me. Death is very rare in this situation, but it does need to be closely monitored. The main concern is getting the metabolism where it needs to be for proper brain development. With proper medical treatment and monitoring, the infant should have a complete recovery and show no signs of a problem, unless he or she lacks of thyroid, and then would need to be placed on thyroid replacement therapies. But again, I do believe that if this hypothyroidism issue is very major from the mom's standpoint, then that brain development could actually have a longer lasting effect in terms of brain function as the person goes into childhood, goes into adulthood, where maybe there's just some minor intellectual struggles, right? They're not going to be a medical professional. Their level of job activity might be lower on the pay scale, just because of that lack of proper development in utero. And if the mom has hypothyroidism, and that is known, then there's going to be a lot of monitoring of the mom during that pregnancy. So right now, with my thyroid issue, I have my thyroid tested once a year. My thyroid levels tested once a year. I'm on thyroid replacement therapy because I don't have a functioning thyroid. But in utero, when I was pregnant, I had my thyroid levels tested every 4 to 6 weeks, just to make sure everything was working properly. And those thyroid levels, because it is a hormone level, will naturally do different things during pregnancy. So if a mom is on medication, those medication levels may need to be altered. All right, whether a person has hyperthyroid or hypothyroidism, tests performed will look at the TSH levels produced by the pituitary and both T4 and T3 produced by the thyroid. These levels can be different and even opposite depending on the reason behind the actual problem. This figure focuses on hypothyroidism, and the following slides will show specific explanations for the reason to the different hormone levels are what they are. So, looking at this first area right here, and I put this slide back up, or this figure here, to show you the connection between the hypothalamus producing the thyroid releasing hormone that acts on the pituitary that secretes the thyroid stimulating hormone, which acts on the thyroid to produce the T3 and T4. Remember, this area is a positive loop where the one hormone is going to act in a positive method of causing secretion of the next hormone. Whereas if you go back to this side, the hormone produced by the thyroid is going to be a negative factor on the pituitary to cause decreased amounts of TSH and also back on the hypothalamus. All right, so the mechanism of hypothyroidism. If it is a primary thyroid malfunction, so the issue is the thyroid itself, what you're going to have is no TSH, no T3 and T4 being produced. The problem is right here. So you're going to have a lack of the thyroid hormone negative feedback on the pituitary, and that's going to cause an effect on TSH. So therefore, with none of this negative feedback here, the TRH and the TSH is going to be in high secretion. All right, so you have the clinical values you're going to see are low TH, low T3 and T4, and high levels of TSH and TRH. All right, so the hypothalamus and the pituitary are sensing that the thyroid is not working, and therefore those are in overdrive to try to stimulate it, but the thyroid itself has the problem. All right, in the second area, the pituitary malfunction. So there's a lack of negative feedback to the hypothalamic releasing of TRH by TSH and the thyroid hormone. So you have low levels of TSH, low levels here because it's a pituitary malfunction, low levels of the thyroid hormone as well because the TSH is low, so it's not going to stimulate the thyroid to produce that thyroid hormone. But the hypothalamus doesn't realize where the problem is, and it is trying to pump out the thyroid releasing hormone. So the hypothalamus senses the low thyroid hormone, the thyroid's not working, it makes high amounts of the TRH, but the pituitary is simply not responding. Hypothalamic malfunction. All right, so if the hypothalamus is not functioning, it's not going to be producing TRH. Those levels are low, and therefore you have low levels of everything. Because the problem is starting up here, the pituitary isn't being given the proper stimulus to produce the TSH. TSH is not being produced, and the thyroid therefore is not being stimulated to produce T3 and T4. So some of these values are opposite of each other, but it's because of the issue up here. Where do you have the problem? So you need to focus on this slide and this table to think about if you were to be given a exam question of what were these values. You would need to try to think about where the problem was. All right, now the next few slides are going to be over diabetes. And because you have the diabetes video, we're not going to talk much about this, but you can still gain some good information for the test in terms of what's going on with type 1 diabetes, pancreatic atrophy, and therefore there's a lack of insulin production, and you have the signs and symptoms of that. It affects metabolism of fat, protein, and carbohydrates, and you can have different types of the development, reasons for the development. It can be immune regulated, where you have cell-mediated destruction of the pancreatic cells. This is probably the most common, where you may have autoantibodies that develop. You may have an infection, say maybe even influenza. I heard a story of this from a previous student, where a young girl, I don't know, she was pretty young, probably between the ages of 8 and 10, where she had a bad case of influenza one year, and about 2 months later she developed diabetes, and it turned out to be type 1 diabetes. And her doctors, the only explanation the doctors had was that the immune response she had when she had the influenza started to tackle and attack the pancreas and cause destruction of the pancreas. All right, there's non-immune, which is going to be secondary to some other type of disease process. Spend some time looking at this figure here. All right, what's going on once you have that pancreatic beta cell destruction? It's going to affect the fat tissue, liver, muscles, and then all the way down here. Eventually, if the diabetes is not treated, it can result in death. Type 2 diabetes, this is the most common type, and it's going to be caused by resistance to insulin. The reasons for this is going to be central obesity, genetic predisposition, physical inactivity. And if you remember that adipose tissue is actually an endocrine tissue, and it can secrete different hormones. If you have too much of that fat tissue, then you can have issues with the endocrine system as a whole. All right, so then the last thing I want to say about diabetes. Major issue within the United States, and there's also a major issue with non-compliance, especially with type 2 diabetes. Sometimes it can be a simple thing of just losing weight, and the patient has a lot of responsibility in that. But there's also cases where the diabetes goes unmanaged. All right, there's a lot of cases when the diabetes is unmanaged or improperly managed, where it's the fault of the patient. However, this is a medical issue. It is very specific to each individual patient, and so there can be cases where a person has diabetes, is doing everything in his or her realm of possibility of trying to manage the diabetes well, following doctor's orders. The doctor and the patient, the PA, the medical professional, has a good working relationship with that patient, but it is just simply hard to manage, and sometimes even impossible to manage. Those are very sad situations, but we need to be careful as medical professionals not to judge a patient when they come in and you see them, or we hear stories of them, that sometimes these medical issues are simply medical mysteries.